Okay, we have the last, but certainly not least, keynote speaker for the CHNC 2025 conference. With us in the booth, Dr. Natasha Henner practices neonatology and pediatric palliative care at Lurie Children's Hospital, Chicago. She is a co-director of a perinatal palliative care program and serves as interim division head of pediatric palliative care. Dr. Henner's academic focus is on improving care for families of infants with life-limiting conditions, particular focus on system improvement and complex communication, exactly what we're going to talk about today. Passions are counseling at the borders of gestational viability, integration of palliative care in infants with severe BPD, and multidisciplinary care for infants with trisomy 13 and 18. Dr. Henner, welcome.
Thank you so much for having me.
We love hearing you speak. You just have a way of making very complicated ethical,
nuanced
conversations seem easy. They're not. And I know you spent a lot of time doing it. I wanted to highlight that you joined us at the Delphi 2024 conference in Fort Lauderdale, and your discussion about the changing landscape for infants with trisomies 13 and 18 was one of the most enjoyed, most talked about lecture of the whole conference. So I really hope that people will check out the YouTube channel and take a look at your talk, because I think if people don't know what the landscape looks like, they may be giving families information that is not correct, and those families will find it. They will find it. So today you're talking to us about something that is adjacent,
somewhat adjacent,
similar, but different. You have a lecture entitled "Intersection of Reproductive Health and Neonatology: Ethical and Practical Considerations." A huge topic. And, we've covered the changing abortion landscape, and a lot of the response that we've gotten has been like, what does that have to do with neonatologists? So why should people spend the next 10 or 15 minutes listening to us?
All right. Well, this is a very good setup. Thank you. This is a complicated topic, and I was asked to make it as neutral as it can be.
Sure.
Which is very easy, as you can imagine, in this day and age. But I really think we need to talk about it as a subspecialty for a variety of reasons. I think there needs to be a shared framework between all the pediatric subspecialists who counsel in the fetal period about what true options are and are not, both prenatally and postnatally, especially if you take away a choice of pregnancy termination.
Right.
Do we have to go all in for certain babies with life-limiting conditions? How do we define a life-limiting conditions? I think people have different feelings about that prenatally versus postnatally, and we have to talk about that. I think there is also an emerging kind of legal landscape to frame perinatal hospice as an alternative to abortion. And that is obviously very sort of near and dear to my practice, because there are truly some states that are trying to legislate conversations around perinatal hospice as an alternative. And the truth is, not every family can access hospice. Not everybody will decide to do hospice, even for a baby with life-limiting conditions. So some of these kids will end up in our NICUs, even though the family has previously maybe wanted an abortion, and now we're providing complex care. And so that is just a difficult new maybe wrinkle in how we talk about that. I think we also need to understand this language of lethal or fatal anomalies as part of the legislative landscape in states that can allow, I guess, kind of like an exemption for an abortion. Like, what does it mean to call a disease lethal or fatal, especially as there's new guidelines for care of kids with trisomy 13 and 18, for example, that say that language is not ethically correct, is it outdated, but we're still using it in some of these abortion exemption laws. And I think we also need to say honestly that there are some maybe legislative efforts to link the abortion restrictions to postnatal resuscitation practices. And that is very threatening to some people, even though the reinforcement of those laws is quite rare. But the fact that it's out there is quite sort of challenging. So I do think that this touches our field in a multitude of ways. And if we don't talk about it for the fear of saying the wrong thing or being too political, it doesn't really actually kind of move us forward. I think the topic is really controversial, but it shouldn't be really controversial to take care of families who find themselves in this bind, both on a societal level, on our local, even like NICU level, and on a subspecialty level where we all may have different vantage points, but still have to come together and care for them.
Right. Oh, what a great synopsis of a very big topic. So how has the changing laws, post-ops, how has it impacted our NICU communities?
So it's a good place to start. I think the changes have been pretty recent. So I think we do have to be careful to say that the last 2 years are really the beginning of the trend, but perhaps they are. And what we know, starting with the state of Texas, it was the earliest state to adapt very sort of stringent abortion laws, even before Dobbs. And there were 2 papers that were published in JAMA in 2024 that look at Texas trends and then compare them to other states with significant abortion bans. And they asked the question, are there more babies born with congenital differences in those states? Do those kids die at a higher rate? And who are those patients? Are they Black? Are they white? And I think the early trends that we're seeing from these last 2 years is that in states with restrictive abortion bans, there are more babies born with congenital kind of differences. More of them are in our NICUs. They're predominantly born to families who are Black. And they're predominantly, again, in states with really restrictive laws. And so that's what we're seeing kind of early on.
And you've alluded to it. So now these babies who may or may not have previously been in our unit are in our unit. Families may or may not have made different decisions about their care along the way. And now we have to decide, what are we going to do at the time of delivery? What are we going to do if a baby is doing well or not doing well in our NICUs? So what are the options?
So I think I kind of alluded to that earlier. I think in a lot of states, or maybe even some kind of like local practices institutionally, where pregnancy termination is not framed as an option for life-limiting conditions, the option of perinatal hospice comes front and center. And it is being kind of positioned or almost sold as this very gentle way to provide supportive care, that these babies don't necessarily have to end up in our NICUs, and that there's just a way to do it differently. And while there is many parents who support that framing because it is their own religious and sort of natural framing, many parents don't really view that as a true choice. That's not what they would have chosen. And so one thing to say about perinatal hospice that I highlight in this talk is that some babies with life-limiting conditions will die early after birth. And so their perinatal hospice approach is provided by people in the hospital, like us. We are skilled in that. We have resources to help babies in labor and delivery. In our postpartum units, they die quickly.
And we have some families who choose that from the beginning, even when they have
a comfort care. We've built entire systems around that. But what happens to those kids who survive to day of life 2? They have to go home, and they go home with a pediatric hospice resource. And most programs in the country are not equipped to take care of children who are dying at home. There is a huge amount of data to say that most programs don't support pediatric care. It's incredibly expensive.
And in particular, infants.
And in particular, infants. Infants tend to stay enrolled in hospice much longer. They have longer length of stays. They also tend to be part of families who continue to desire ongoing care. There's data to suggest that the longer you're in hospice, the more therapies your family is actually going to want to provide, because the narrative flips. Right now, this baby with, let's say, trisomy 18 is 2 months old, and he hasn't died yet with this wonderful hospice approach because they still have some natural skills. And people say, well, what about an NG tube? What about that cardiology evaluation for a VSD? And you start entering this more complicated sort of concurrent care space of ongoing ICU care and hospice. And the truth is, nobody's paying for that. Private insurers are not paying for that. So then parents are forced into a binary choice. Either continue with all life-saving interventions and just stop hospice type philosophy, or forgo everything and allow that kid to die. And very few people do that. Again, if babies don't die early in life, you guys all know that framing shifts. That baby becomes a miracle. There's a lot that's being attached to that. So I think that's one issue with hospice. And another one is that as pregnancies evolve, even though parents commit to one pathway, with social media, maybe with some outside pressures, people just flip and now say that even though I desired an abortion, now I want this baby to survive. And I think we have to accept that.
And obviously we don't have a lot of data, but in your sense speaking to others, it seems like when the time comes, most parents are still not electing comfort care. So we are bringing in this whole new population of families that are choosing intensive care. What is that?
With a very high mortality risk, though.
So with high mortality risk, but higher risk of having a survivor with chronic critical illness.
Yeah.
Right.
And so I think that's a subset of patients that we already struggle with in our NICUs. They have tremendously long length of stay. They cost our healthcare systems a lot of money. We all know that. It is hard to build bridges to the outpatient care for these kids. And so there will just be more kids with chronic medical complexity. And I am not at all suggesting that more people should have pregnancy termination for life-limiting disease because survivors cost so much money. Like, that is not the message. Yes, they take up more of our NICU space. Their care is much more expensive. What we should do if those kids are now with us is to build all those bridges, right? To support those families better, to diminish the sense of guilt, to have more, like pulmonologists within a driving distance of a family, which is not currently the case.
Right.
And we just have no current signals that we're working towards that goal. We're in fact shifting away from it with all of the other sort of political landscape happening, right? Like diminishing the rates for the Medicaid coverage, like not having paid parental leave. Like, if we're going to have more of these kids, we should be all in for supporting them postnatally and not less in.
Right.
Interesting. So we've kind of talked about one trajectory, right, where many families will still elect intensive care when given that option. And on the converse, you are describing that there are a number of pathologies for which we used to routinely recommend comfort care or even termination when it was an option, then now the consensus is changing a little bit. And I think that has something to do with, again, your discussion about what is fatal, what is life-limiting, and how do we use those terms to make decisions for families.
Yes. I think this is actually incredibly complicated and it's very unit-based and maybe state-based. But if you use, for example, a diagnosis of single ventricle, right, so hypoplastic left heart, we routinely offer an option of either pregnancy termination or hospice care in those pregnancies. In fact, there's data to suggest that almost all cardiologists and CV surgeons support that approach and would choose that for their own hypothetical pregnancy. Now, after those babies are born, there are some centers that don't offer comfort care for single ventricle babies.
Even though they
would have offered a termination or would have considered, again, a hospice approach maybe prenatally for themselves. They won't offer that postnatally. And you can argue both sides of that equation. You can say, well, the outcomes of hypoplastic left heart are better than they were 10 years ago. You can say that, you know, the death rate between stage 1 and stage 2 repair is 5 to 15%. Now, you can look at that number and say that's very high, or you could look at that number and say it's actually quite low and it's better than it was 30 years ago. You can say that about 20 to 25% of those patients need a heart transplant in the future, and you can use that as a hopeful framing that with a heart transplant you can continue to live. Or you can use that with a negative framing to say heart transplants is not a guarantee of anything and you're just exchanging one chronic disease for another. But if you are in a center that doesn't offer essentially non-intervention pathway for a hypoplast, what does that mean? Are we going to mandate surgical intervention? And I think most people say we're not ever really going to get to that because it's a complex, chronic surgical disease.
Right.
And so we can't do that. But then how do you signal that to parents? And I don't actually think single ventricle is the only example for babies born 22 to 24 weeks gestation. Like, what level of complications postnatally justifies a conversation about a redirection? And I was part of the study that showed we do not agree on the degree of postnatal morbidity that would prompt us as neonatologists to offer non-intervention in this baby, whether
and
it's
on my own team.
100%. And so how can we say that if you don't have access to abortion, you will have all those choices postnatally when we don't have actually good agreement whether we have those choices, whether it's for significant congenital heart disease, periviability, kids with kidney disease is another very interesting bucket, right? Is dialysis optional? There are some people who say it isn't. That the outcomes are so good for certain groups, we shouldn't really frame it as an option. And some people say, how can that be? It's always optional.
Right.
There's disagreements based on weight at initiation of dialysis. Again, and so I think we're putting these parents in a bind by restricting one choice and promising them they will have others postnatally where we don't have agreement as a subspecialty. And we might also be on the flip side of that, really clouded by that guilt, right? We may offer choices of non-intervention for a kid with a really good outcome because the parents wanted an abortion, and we have all this, like empathy around that, and perhaps offer to withdraw therapies from a child who would have done really well. Because again, we have this misplaced sense of empathy almost. So we have to be really careful about that.
Oh, interesting.
So complicated.
Yeah, but I think, in the complex conversation we're having, what is inherently clear is that the expertise that we have in terms of how we care for families of children who are medically complex, who face life-threatening conditions and disease processes, that we have that content expertise to the conversation about these policies and laws before birth, right? In some of these landscapes, like I think you're making an excellent case for why pediatricians and specifically neonatologists really have a voice to add to this conversation.
Yeah, absolutely. Well, speaking of which, how has it impacted us? You have this slide. Does the concept of fetal personhood affect neonatal resuscitation practices? And same thing, we covered this on the podcast, and people in general were saying, no, I don't think it does. But in practice, it certainly feels like it has made a difference.
Yeah, this concept of fetal personhood, it is perhaps a moral or a political one, but it's not a medically established concept, and I think we have to name that. I think there's a lot of historical context around that particular point with like the Baby Doe amendment and the Born Alive Infant Protection Act of 2002 that essentially establishes personhood in any baby who's born with any signs of life, but it doesn't necessarily direct the medical care. But unfortunately, there have been some recent efforts to tie fetal personhood to postnatal resuscitation practices.
Right.
So the Federal Research Council, which is a conservative group, has in fact posted on their website that there are states that have very strong infant protection laws and there are states with weak ones. And there is a new act that's pending in Congress called Born Alive Abortion Survivors Protection Act, which is a mouthful and also just kind of hard to conceptualize what it means, that essentially states that any infant, even that infant born as a result of an abortion, should be looked at and evaluated by a neonatologist and potentially provided life-sustaining therapies. And while those laws have never really been enforced, I think the threat that it's out there is something we need to talk about.
Absolutely.
And again, I think it's ethically problematic to conflate fetal personhood to postnatal resuscitation because it just goes against shared decision-making, against the AAP statement. And so it's really all the professional bodies.
Physiologic parameters.
And this was clearly not the intent of that family.
Right.
And so we're really overstepping. And so again, when you look at the historical context, there have been very few true legal cases where that was even brought to court. So I don't know that we need to be super, jumpy or sensationalize that in any way as a threat, because I think that's another argument. Like you say, everything's on fire and then nobody really believes you. So I don't know that this one is really where the true fire is, but still definitely something to talk about.
Yeah, I mean, it certainly impacted our presence on labor and delivery. So in the state of Florida, in our system, if a baby is delivered after 15 weeks, then we're presenting to those deliveries.
You are?
Yeah, we're not. We are still following our kind of national, kind of consensus on viability and
professional sort of lens. Yeah.
But they expect us to be there. So it's really complicated. I think it's really confusing for parents. Why are you bringing this professional here if they won't be performing any,
and the state variation piece is really what contributes to this conclusion too, right? Because in this day and age where the stories are just populating our social media feeds, in the context of one story in one state with its own policies and its own laws, and the hospital and the providers within that state making certain choices, like this is where we get to some of the conversations now about how these policies then trickle down into the conversations between neonatologists obstetricians and the families, right?
Absolutely.
The confusion that happens because that context is lost and because the context is muddied by the state variation.
It's muddied and it has so many feelings around it, right? We all come into that as humans with our own political perspectives, our family values, our professional values. It's never going to be the same conversation amongst all of those groups. We're all going to bring something to it, but it's not fair to parents to not know truly what the answer, what are the real choices prenatally and postnatally.
Right. Incredible. So what solutions have you come up with for us? The one that I think I underline, highlight is obviously an evolving role for perinatal palliative care. And I recognize that as neonatologists, we feel like we do perinatal palliative care, but it is a specialized field. I think you're the perfect person to speak about that. Why is it important for us to not do this alone, to engage our palliative care colleagues, to encourage neos who are interested in palliative care to get additional training?
I mean, I'm obviously very biased, thinking it's a very needed field, but I would say that primary palliative care skills are critical. And so even if you have a budding pediatric palliative care program, still leaning on those people's expertise to teach your NICU fellows perinatal palliative care skills, to talk about that, to do some simulations around this topic even, which I bet nobody has written about. And it is a hard topic to speak about and to write about. But, we are very lucky at Lurie that we have a whole track dedicated to the perinatal palliative care training. We have a massive program, but there are many hospitals that don't have those resources. And so how do you then talk about it? And how do you talk about it as a group? And I'd say the first step is pose it as a conversation topic in your division meeting. Talk about it openly. But I think because people are skittish around it, because again, it always has a political undertone, somebody has to set the stage to say, we're not going to frame every single conversation the same way. Again, we're all people in it. But how do we as a division maybe kind of dive into this problem? How do we address it together? But there's just not a lot of appetite to do this in conference rooms for, I think, very obvious reasons.
Well, but I think you mentioned something that I think you can rely on, right? When we in medicine have really struggled with communication and conversation, simulation it's coming time and time again. The evidence is showing that simulation is what helps us as healthcare providers do better in those conversations that elicit all of those feelings in us as humans, that really maybe unmask our biases in whatever way, shape, or form they might arise. And so simulation for not just palliative care conversations, but specifically around this topic feels like a very important area for our medical education leaders and any trainees who are interested in medical education, because that is a concrete thing, right, that we can develop. And that doesn't need to be in person, right? Especially nowadays, we have a lot of virtual platforms, virtual strategies to practice these conversations.
Absolutely.
And so that's what I heard you say, and I'm just going to highlight it for our MedEd listeners, is that this is content we need. Yeah. These are strategies that we can work on.
I couldn't agree more. And I think if we're building something like a sim curriculum around that, or again, even a divisional level conversation, forget sims, right? They're expensive. They take a long time to get off the ground. You have to start somewhere. I think it is flawed to just get a bunch of physicians in a room and talk about it. You have to get your social workers and your bereavement counselors and your chaplains and your nurses. And maybe, somebody from your legal office and somebody from ethics.
Your OB department.
Your OB department. They're all going to have a role to play in framing this conversation. And it is becoming muddy, right? How do I address a conflict with a colleague, for example, around this? How do I frame that one of my partners offered perinatal hospice approach to this family, but I wouldn't have,
or how do you navigate service when this baby delivers? And
exactly. And I do think we're sometimes kind of blindsided to say, 13 docs are going to get in the room and bang it out. That's just not what happens in real life. We all know that there's multiple teams who are kind of touching the care of these kids, and we should be really talking to them as well.
And I think you highlight in one of your slides, I wonder if that conversation is so difficult because some of us aren't even sure what, right? Even I think people who would have made concrete decisions or recommendations around peri-viability or trisomies or complex congenital heart disease, by the changing sociopolitical climate, it does even, I think, on a professional level, make you second guess, some of potentially some of those choices. So you highlight that people might be having moral distress about this whole conversation. And anyways, we've been talking about normalizing feelings. And so I just wanted to highlight that, that you had mentioned that, and how should people deal with those feelings?
I mean, the only way out is through, right? Like you have to sit in the room and or just have like a personal conversation about it. And we've always had moral distress in our NICUs. I think, so much has been written about why that is, why this patient population makes us so primed for moral distress. And there is probably 100 reasons, right? Disagreements between how nurses view outcomes and how physicians view outcomes. Disagreements about cost of care and the value of a short and a disabled life. Things like that. Like there's just so many balancing points that are hard. But we're now kind of introducing a whole new array of moral distress into this. I know there's some units that have more kids with medical complexities whose parents wanted an abortion, didn't access it, and now really can't parent that child.
Right.
Where does that child go? I say,
Stays in our NICU.
This stays in your NICU, right? And so we have to talk about what do we do about that new type of moral distress? What do we talk about? I think an important tension that there are some states where the pregnancy termination limits are high, let's say 24 weeks. But we know there's babies who survive at 22 weeks.
Right.
That is something we have to talk about, whatever your political affiliations lie, and then balance that with a congenital screening that really is around that 20-week mark. Like, how do you balance that triangle, and whose benefit is this all? But again, like, we just have to name that is a normal moral distress feeling, kind of regardless on which side of this, sort of this conversation you sit on. And again, I think the provision of life-sustaining therapies to very chronically ill kids whose parents previously stated they wanted an abortion is a whole new topic. Like the guilt that's probably now wrapped up into this much more miracle-based narrative and other things that people will lead with is already something we very much struggle with.
Sure.
We do not love that miracle framing. And I think a lot more is going to come our way in that. And we have to kind of just sit in it and talk about it.
I couldn't agree more. If for people who are going to be able to watch the talk live, her last slide says it so wonderfully. Not just expect a complex dialogue, but we in the neonatal field have to welcome that complex dialogue. And I think we do hard things every day in the NICU when we prepare for really hard things every day, and so we should not shy away from the complexity of this conversation.
I agree. Thank you for saying that. I think there's a lot of fear of saying the wrong thing even in private conversations, let alone in big rooms. But that fear should not hold us back in just naming, right? Like I kind of like as a palate to say, like you have to name your own problem first. And so name the tension, name the stakeholders, name the differences, start by doing that. But I think the discomfort of the topic is holding us back.
Okay. Well, thank you for giving us the motivation to sit with our teams and start talking to one another about how this is impacting ourselves, our hospital systems, and the families and babies that we care for. We always love having you. Looking forward to speaking to you again in the future.
Thank you so much. This was fun.
Pleasure.
Thank you.